So there are many professional organizations that serve on our board. You can see that this is officed and staffed at the American College of Surgeons, but it is governed by a multidisciplinary board and not by the college. So all of those organizations you see there, other than surgical organizations, of course, ASCO, the plastic surgeons, the Astro and radiation oncology, the cancer executives. You know, if you don't have the administrative leadership of your hospitals understanding the relevance of accreditation for both cancer and breast cancer, you're not going to move things as fast as you should. So we have the cooperation and participation of the executives in this area. Social work, the CAP, obviously an important part of this, and the backbone of any registry system are the cancer registrars. The NCBC, which is an organization that preceded us by many years, is a part of this board and was one of the founding members, actually. The genetic counselors have come aboard. The Oncology Nursing Society, we recognize, obviously, the central importance of nursing in this endeavor, the SSO, and then members at large. Now, there are 17 required components. When we first put this program together, we tried to define the entire continuum of optimal evaluation and management of patients with diseases of the breast. And they've been revised and updated, but interdisciplinary conference we have felt is essential to have a good discussion prospectively of patients with diseases of the breast. Obviously, data management I mentioned. Patient navigation has been identified as a key component to our program, and you'll be hearing more about this this morning from Lily Shockney. Survivorship programs have been more recent. Obviously, pathology and imaging, needle biopsy rather than open biopsy as the initial step, and at least in our literature in the United States, even recently there's been identification of a gap and a deficiency in that area. There's still too many surgeons who are doing excisional biopsies as a first step in diagnosis. Surgical care, of course, is centrally important. Radiation and medical oncology, nursing, genetics, education, support, and rehab. We have a new standard for plastic surgery consultation. We're going to require that 80% of patients who are undergoing mastectomy have at least consultation with plastic surgery. We embrace research, whether it's cooperative group clinical trials or locally administered research programs. And I've alluded again to quality improvement. So these 17 components, I should mention, could be provided on site in centers with walls or without walls, or referred. Most of the centers we've accredited so far have either all of these components or at least 14 or 15, but some of the smaller centers refer patients for genetic counseling, for example, to a nearby center. So as long as a patient has access to all of what we have defined as required components, we feel like that satisfies our requirements and we're not compromising our standards. We initially set out, Ben and others, looking at a 3-tier accreditation system, big centers, medium-sized centers, smaller centers, and that really didn't fly in our system of healthcare in the United States. And that's how we evolved this concept with the help of NCBC with provided or referred services. And that allowed us to move to one single level of accreditation rather than 3. We have 27 standards, or 36 standards for the Commission on Cancer. As you can see from this list here, that it's a very patient-centric set of standards in Chapter 2, with 19 of our standards relating directly to evaluation of patients and management of those patients with breast disease. 3 of our standards must be met before we can even agree to survey a program. Standard 1.1 defines authority for the breast program leadership within an institution, whereby it's clearly stated in an operations manual or bylaws of the professional staff that the breast program leadership has the authority to go forward with and to run this program. Secondly, the Interdisciplinary Breast Cancer Conference I've heard comments early in the program when we were having political barriers to getting this program going that we don't really need to have a breast conference. We talk to each other about our patients. We call each other on the phone or we email, and that's fine. Communication is fine, but there's no substitute for a thoughtful interdisciplinary breast cancer conference in which the pathologist will project the slides, the breast imaging people will project the images, and the geneticists are in the audience to remind some of the clinicians that, this patient really should be referred for genetic counseling, and so on. So there's no substitute for that, and it's one of our core requirements. And then you can't just set up a breast cancer center, put a sign in your private practice office, and call it XYZ Breast Cancer Center. You do have to demonstrate that you can do it in an office, but you have to demonstrate that you have collaborative relationships, formal collaborative relationships with all the essential colleagues in this area, the professionals involved. We collaborate with many organizations and embrace these programs in our standards. This doesn't mean necessarily that they are required, but they may be someday. The ASBS has a very fine program which is growing rapidly in the mastery of breast surgery, the leaders in the audience. ASCO's COPI program, we've had many conversations with them. The PARROT program of ASTRO, and we audit actually in our survey application record how many of the medical and radiation oncologists are participating or plan to participate. It's a way of sort of reminding them that this is a good thing. So the CAP, we look at the College of American Pathology protocol for path reports. That's part of our survey. I mentioned the NCBC and then, of course, the ONS, the Certified Breast Care Nurses. And as I do surveys, I've really been pleased to see the level of competence and dedication of the nursing staff at these breast centers. We have a lot of voids here. We need to fill these voids. You can see from the geographic distribution here where the accredited centers reside so far. And so your commitment to providing high-quality breast health care, the NAPBC really grants these centers this level of accreditation that are voluntarily committed to provide the best in breast cancer diagnosis and treatment and comply with our standards. This is not a mandatory program. It's not a federal program. It's a voluntary program, as is the Commission on Cancer. So this evaluation occurs every 3 years. We now have about 45 trained physician surveyors for NAPBC, about the same number as the COC. Some do both. Many are surgeons, but we also have radiation oncologists, medical oncologists, and pathologists. Looking to the future, we're going to continue to look at our standards as the Commission has been around a lot longer, and we look at our standards about every 6 years. We want to raise the bar across the country. We've identified new quality measures, and this the survey application record, the SARS, this is all electronic. It's green. There's no paper involved. It's all transmitted electronically, and we believe we can embed within that system a database. We really believe it can have a significant impact on the continuity of top quality comprehensive care for patients with diseases of the breast. As I said, we have 170 centers now formally accredited. We've had some that we've surveyed that have not met the standards, and they are resurveyed after 1 year. We have other centers that have failed to comply with 1 or 2 or 3 standards, and those centers are given 12 months to correct those deficiencies. So we have centers, 95 centers are presently scheduled for survey, so we will be at almost 300 centers probably in the next 12 to 14 months. Over 1,300 centers have expressed interest.